going to go through an introduction on how to present pediatric chest X-rays and how to approach this. So when we're interpreting a chest X-ray, there's many things that we need to assess, such as the lungs, the heart, pleura, and bones. So it's useful to have a system in your head to remember everything. So outlined here, we've got an example, A to G, which covers everything you need to look at. And I've starred the lines and tubes and placed that at the top because, especially in the pediatric setting, lines and tubes are very important because misplacement of these can lead to significant consequences. So we need to make sure that we assess these first, both in real life and the exam setting. And then we've got the rest, airway, breathing, cardiac, and so on. So we'll go through these now. So with A, airway, we want to start off looking at the trachea. You're looking at the size of the trachea, caliber, is it deviated? So the trachea normally is a bit deviated to the right because of the aortic knuckle. You want to see, is there a visible foreign body projected over the airway? And especially with the children, they're frequently putting things into their mouth, and then they might present with breathing difficulties, and you might not necessarily get a history of a foreign body ingestion, so you need to look out for this. And then there's things such as the steeple sign in croup, which patients might present with, where you get narrowing of the trachea. So we've got an example here of the steeple sign. So you can see you see my arrow?
Yeah, we can.
Oh, thank you. Yeah, so we've got this arrow that's pointing towards the narrowing of the airway, and you've got that you've lost that normal convex shoulders on either side, where the transition to the larynx is, and you get this inverted V appearance, which resembles the steeple of a church. Okay, and then you want to look at the right and left main bronchi, check that the anatomy is normal. Can you see any variations of anatomy? Sometimes you might be able to see these on the chest X-ray. So you've got things like pig bronchus, duplication, or even absence of bronchi. And again, you're looking for foreign bodies. So this is just an illustration of the different variations of the bronchi that you can get. So you've got the main two types, which are displaced bronchi or supernumerary. And the difference is basically, so with displaced bronchi, you've got the usual bronchial supply to the affected lung is concurrently is absent. So here you can see that this apical segment is absent from its normal place, but then you've got it coming off directly from the trachea. Whereas in the supernumerary bronchus, the rest of the bronchial anatomy is present, it's all there, but you've got this extra supernumerary bronchus. And you can see this supernumerary bronchus on this coronal CT slice as well. So this image on the left just shows foreign body. So you've got this radio-opaque rounded foreign body projected over the upper airway. And this was in a 6-year-old boy who ingested 2 coins, and these were lodged in the esophagus here, and they were superimposed upon each other. So, and it gives the appearance of a disc battery, which is another thing you need to be aware of because you get this lucent edge. So here you can see this crescenteric lucency in the superior aspect, but these were actually 2 coins that were superimposed upon each other. And here we've got the steeple sign again, narrowing of the upper airway. So breathing, you're mainly focusing on the lungs. So you're looking at each of the lung zones, you're assessing the volume of the lungs, and you want to be able to see most of the heart above the diaphragm. So if the percentage of the heart below the level of the hemidiaphragm should be less than 1/3 of the entire heart height. Another thing you look at is the curvature of the hemidiaphragms. So these should be just mildly curved, but not flat or everted, as you can see here. So this is a normal, well, not normal, sorry. You've just got the curvature of the diaphragm here. which is normal. So just going back, another thing you can count is 5 or 6 ribs, and these should be present above the hemidiaphragms. You're also looking for a pacification. So that would suggest that there's replacement of the normal air in the alveoli by something else. So this could be infection or pus, fluid, blood, or cells. So you want to correlate that with the lobar anatomy depending on which zone is affected, and the contours that are obscured, such as the right side of the heart or the left side of the heart or the hemidiaphragms. And then finally, also ear trapping. You tend to get that quite commonly in children, especially who've ingested foreign bodies. So you're looking for a hyperlucent lung. So that's what this example was showing. So you can see the left lung is hyperlucent when compared to the right side. It's also inflated. And this patient had a radiolucent foreign body lodged in the left main bronchus. So these can be confirmed with inspiratory and expiratory views. So you get persisting hyperlucency of the affected lung. Another thing you can also do is fluoroscopic studies. So if you lie them on the presumed affected side, you won't see any movement on inspiration and expiration of that lung. And then also you're looking for the pleural spaces to check for effusions as well. So moving on to circulation, you're looking at the cardiothoracic ratio. In children, because the most radiographs are taken in the AP position, the normal cardiothoracic ratio can be up to 60%. So that can be normal. You're looking at the pulmonary vasculature, so you're assessing the lung zones, looking for increased vascular markings. So normally you should see the pulmonary vasculature from the hilum extending out into the peripheries, but they taper off, and you only see few vessels in the outer 2/3 of the lungs, and the diameter of the pulmonary vessels themselves should be less than the accompanying bronchus. So in the case of pulmonary plethora, you'll get the prominence of the peripheral parenchymal vessels, as you can see here. And sometimes you'll get dilated, tortuous vessels extending further out into the peripheries, and the pulmonary artery diameter will be greater than the accompanying bronchus. So this case just demonstrates a child with cardiomegaly secondary to a ventricular septal defect, and they had pulmonary plethora. So you can see there's lots going on both sides on the lungs, and you've got these dilated vessels, and you can see them extending far out into the peripheries, which is abnormal. And then moving on to D, so diaphragm, you want to check all the contours. As I said earlier, mild curvature is normal. It must be crisp and clear. If not, then if you've got a pacification, obscuration, there's something going on that's causing that blurring of the diaphragm. So congenital diaphragmatic hernia, so if you've got intra-abdominal contents being pushed into the thoracic cavity, that will cause an abnormal contour of the diaphragm. Other congenital abnormalities such as sequestration. Another thing to be aware of is the deep diaphragm sign or deep sulcus sign on this supine pneumothorax, such as the one seen here. You've got the arrow, so you can follow the diaphragm all the way through. That's because there's air trapped between the heart and the diaphragm, and this was a case of pneumomediastinum, which was confirmed later on the CT. So you shouldn't be able to follow the diaphragm continuously below the heart. And then you've got the deep sulcus sign, as I was saying earlier. This doesn't demonstrate it, but you'll see the sulci extending much more inferiorly than normal, and that's the sign of a pneumothorax on a supine film. Don't have an image there. So E was for edges. You're looking, as I said earlier, with the contours, but you're following the mediastinum as well. So in children, you've got the thymus as well to be aware of. So you might get a slightly bulky upper mediastinum because of the thymus, but you need to be aware of what is normal. looking at the hilum as well, the size and the density to see if there's any added densities that might suggest nodal enlargement or a mass. And then following the pleura laterally all the way up to the apices to check that everything is clear. So the thymus has a variable size and appearance. Usually you don't see it in children above 6 years because it obliterates. Then it's a soft structure, so it can have a varied configuration. So we'll go through those as well. So if there is atypical widening of the thymus, you want to consider ultrasound assessment because you can get pathologies such as neuroblastomas, lymphomas, teratomas or germ cell tumours, or even thyroid pathology extending from the neck. So yeah, in neonates, it's the most prominent up to 2 years. Relative to the rest of the thoracic volume, and you only see it in about 5% of children greater than 5 years. And the right side is usually more prominent than the left. And you've got loads of different configurations that you can see. So here you've got one appearance, and then you just got other images. So the other configurations you can get are the Sale sign, the Spinnaker sign, or you can just get some slight indentations or scalloping, but it can be continuous with the right heart border. So the thymus itself is quadrilateral in shape, and it extends from the level of the manubrium down to the fourth costal cartilage. It typically has a smooth outline but because of its close proximity to the costal cartilages, it sometimes can be slightly scalloped or indented, as you can see in some of the images here. And it's usually prominent on the right. So then F for foundation, so you're looking at the bony skeleton that you can see, and you're looking for fractures. So this can be in the context of trauma or NAI, looking at the density of the bones. Is there any evidence of metabolic bone disease, infection, and then skeletal dysplasias as well, which you can see in children. And then so finally G for gadgets. So we're going to talk about this. So these are basically lines and tubes. As I said at the start, you need to assess these first, but for the sake of the presentation, because we'll be going through cases of lines and tubes, I've left this till the end. So we've just got the variety of lines and tubes that you might come across just outlined here. So airway tubes, feeding tubes, drains, temperature probes, and then you've got your long lines and central venous catheters. So this image demonstrates a NJ tube, so you can see that the tip is on the left, in the left upper quadrant within the jejunum. So this is a replogal tube, and it's used in the treatment of babies with esophageal atresia. It's a double lumen tube, and it's inserted through the nostril into the blind ending esophageal pouch, where it's used to drain the the secretions that build up, and that's to prevent the risk of aspiration pneumonia. So you've got these two outlets. So you've got this suction tubing, and then you've got the second inlet where you can insert saline and air. And this last image just shows the Amplatz closure device, which was used to close off an atrial septal defect. Okay, so we're going to focus on the lines and tubes now. So I'll just quickly go through the correct positioning. So the ET tube, the positioning can vary considerably, but that depends on the head and neck position. But so you need to take this into account when assessing for this, but it needs to be above the carina. And you need to make sure that it's not too far down into a bronchus, because that will occlude the aeration of the opposite lung. NG tubes need to pass the midline, bisect the carina without deviating above the hemidiaphragm, because that would suggest that it's in the lung. It must cross the hemidiaphragm and then veer to the left and be projected over the gastric bubble. You've got umbilical artery catheters and veins. So the umbilical artery catheter, that dips down first and then it travels upwards into the aorta. So it goes into the internal iliac artery, then the common iliac artery, and then the aorta. And the tip of the umbilical artery should be placed so that it's avoiding the origins of the major vessels. So you've got two positions. You've got the high position, which is around T6 to T9, or the low position, which is around L2 to L5. So that will avoid the bit in the middle where the visceral branches come off the aorta. The umbilical venous catheter, so that goes straight upwards and through the umbilical vein, through the left portal vein, the ductus venosus, and then into the IVC, and the tip should be at the junction between the IVC and the right atrium, so just about here. And then you've got peripheral lines and central lines. So the tip positions of these can vary, but you ideally kind of want them around the cavoatrial junction or right atrium. And especially with the central venous catheters, they need to be placed so that they are distal to the last venous valve, which is located at the tip of the internal jugular vein and the subclavian vein. So it can be projected anywhere over the brachiocephalic and superior vena cava and cavoatrial junction. This image just demonstrates a portocath. So you can see it's projected, it's gone through the subclavian vein, the superior vena cava, and then the tip is here projected on over the right atrium. Okay, so this is just the normal positioning of all the lines and tubes. Okay, so we're going to start off with case 1. Have we got candidate 1 present?
Yeah. Good evening. Are you able to hear me?
Hi. Yes, I can hear you.
Yeah. Good evening.
Okay.
Yeah.
So this is case 1. If you can, start presenting your findings.
Yeah, I've been provided with a frontal chest radiograph of a skeletally immature patient. I will quickly go systematically through the images. The airway appears normal, and going to review areas of the chest, the apices, the bilateral hyla, the hemidiaphragms appear normal. Now going to the circulation, the cardiac contours appear normal. Going through the diaphragm, the diaphragmatic contours appear normal. Apart from this, the edges, there is no evidence of any blunting or obscuration of the right costophrenic angle. However, there is decreased. I couldn't see the left costophrenic angle due to there's I think it is not covered in the film. And apart from this, I'm going systematically through the bones. There are no fractures or focal lesions in the bones, and there is a radio opaque tube overlying the right chest wall with the proximal tip in the the second intercostal, at the level of second intercostal space, and the tube goes down below into the abdomen. So I would like to know the history of the patient.
So they inserted a line and then they just wanted to check the positioning.
Yeah.
There was no other.
I'm thinking. I think the line appears normal. There is no kinking or breaks in the line. So I'm thinking in terms of any like a peritoneal shunt that is opening into the vein. Peritoneal shunt, like going from the abdomen into the subclavian or the jugular vein. So I'm thinking in terms, but there is no kinking or any breakage in the tube.
Okay.
So I would like to have a furthermore history for what the patient has been put the tube for, and I would like to discuss the case with the referring physician.
Okay. So they told us that they put a central line through the right internal jugular vein, and they wanted to check the positioning of the tip.
Okay, right intellar jugular vein. Yeah, the tip. I think it is not in the right intellar jugular vein. The tip should be in the right atrium or this SVC cava atrial junction. Yeah, but I think it is It is not going into the jugular vein. It has taken a route, I think, to another like a superior epigastric vein. I think. It has taken the route of superior epigastric vein. Apart from this. I couldn't see any other abnormality. It is not in the tip is not in the cava atrial junction.
Yeah, no. So is this what you're talking about? That
Yeah.
You're saying the tip is. So where do you think that is? So if they've inserted it through the internal jugular vein, so where you're right, it's not projected over the superior vena cava or the.
I think it might have gone into the axillary or the subclavian vein.
Yeah. Yeah. Okay.
Yeah.
Yeah. So this. Yeah.
Okay.
Yeah, so this was a malpositioned line. So it was an internal jugular line. So you can see that this is the insertion point. It travels caudally, but instead of going into the brachiocephalic vein, it's right. So it's gone into the subclavian vein. So this is a malpositioned line. So this was a central venous catheter, and yeah, you're right. The rest is normal. So yeah, so good. So you got that in the end. But you also need to just make sure that you comment on the lines and tubes first.
Okay.
So I know, it was good. You went through the A2G framework. But comment on the lines and tubes first, and then say, you want to inform the referrer and make sure that they replace this line as soon as possible. You need to make sure that they're aware of that.
Okay.
Good. Okay, so we've got case 2. So I've got 2 images here. If you start off presenting the first one on the left, so this was the radiograph which was done first, and then the second radiograph on the right was done an hour later. So if you start off presenting this one.
Yeah, I've been provided with a supine portable radiograph of a skeletally immature patient. I would like go through the lines first. I could see the endotracheal tube, which is above the level of carina, and I could see I think there's a tube, nasogastric tube. I think it is coiling within the mediastinum. It has not gone into the left beneath the left hemidiaphragm. There is a malposition of the nasogastric tube, and apart from this, I could see, I think, a butterfly, central venous line projected over the right side of the neck. Yeah, I think it is going into the cava atrial junction. Apart from this, I would cava atrial junction. So the main thing is the malposition nasogastric tube, which is coiling in the I think within the esophagus, but not going into the stomach. It is not going beneath the left hemidiaphragm. So I would this is the main finding. The other, I would like to systematically go through the other areas like the airway. I think it appears unremarkable. The lungs, the epices, hyla appear unremarkable. Apart from this, see the cardia and this appears unremarkable. The diaphragm appear unremarkable. The edges, the costophrenic angles appear unremarkable, and the bones appear unremarkable. So my main principal diagnosis is the malpositioned nasogastric tube, which is coiling in this one. And I would like to add a point. The patient had a fixation for this spine, likely for scoliotic deformity. I'm supposing transpedicular screw fixation. And apart from this, I think the another radiograph that is taken 3 minutes later, I think, if I'm correct, 3 minutes later, I think the nasogastric tube has passed through into the right lower lobe. I think there is bronchial intubation. I'm thinking of bronchial intubation of the nasogastric tube, which has gone through the right lobe, and it is going. Yeah, the distal tip is in the right lower lobe of the lung. Yeah, I think this is the malposition tube we are seeing. I would like to know better the history of the patient. Yeah, for what these tubes were kept. The endotracheal tube and the central line appear normal, but the nasogastric tube, I'm thinking it has gone into the right lower lobe.
Yeah. Okay. So what would you do? So you've seen this radiograph.
Yeah, I urgently inform the referring clinician and urgently inform the pediatric team for the malposition and do the correct position of the tubes before they do any other procedure.
Yeah, good. So if you spot this, you need to make sure you pick up the phone, call them, make sure that they don't use the nasogastric tube for feeding, and they need to remove it and replace it as soon as possible. So good. So you picked up the coiling of the NG tube in the distal esophagus in the first film, and then the second film they tried again, but it went down the right main bronchus into the right lung.
I have a small doubt here. I couldn't see the lead distal marker in the NG tube. Yeah, I am having a doubt with that one.
The distal marker, sorry?
Yeah, they have a radio opaque marker distally.
The tip. Yeah, sometimes it just depends on the make of the NG tube. Sometimes they don't always have the dense tip.
Okay.
So good. Yeah, and you commented on all the other features. So in your pacification in the lungs. And so this was a scoliotic patient. As you can see, they've got a long segment spinal fixation. And in these types of patients, it can be quite difficult to site the NG tube correctly because of the neck and the chest positioning because of the scoliosis. So they tried again, and on the third attempt, they managed to site the NG tube correctly. On this image, we can't really see the tip, but we can see it's below it crosses the hemidiaphragm, and it's on the left side. Okay, so good. So this is just an NG tube checklist. So, I mean, on the wards, if they are able to obtain an aspirate, which is of alkaline, then that's fine. But if they can't, then patients will tend to go on to have a chest X-ray to confirm the positioning. And you need to make sure that it follows the path of the esophagus, bisects the carina, crosses the diaphragm in the midline, and then is seen on the left side below the diaphragm. So this is just a checklist that can be used. Okay, so this is case 3. Are we still with candidate 1? Or?
Yeah, I'm here.
Okay, good. So you can present this case, please.
Yeah. So I've been provided with a frontal radiograph of the thorax and the abdomen. First, I would like to comment on the tubes. I could see the one catheter going inferiorly to above. I think this is a umbilical venous catheter because it is not going down, it's going directly on the right side of the patient, going on the right side of the vertebra in the right paravertebral region, and going very high up into the area of the first intercostal space. So I'm thinking of a malposition umbilical venous catheter with very high position. And apart from this, there is another tube that is going parallel to this one. But there is no kink in the tube, but it is going parallel to this one. And it is present at the level of 1, 2, 3, 4, 5, 6, sixth right intercostal space. I couldn't make out what tube is this one. There is one more tube that is coming from the cranially and going into the abdomen. This can be any ventriculoperitoneal shunt. And apart from this, there are a few other tubes in the left quadrant of the abdomen overlying the abdomen. And apart from this, I would like to go systematically now that I have sorted the tubes, except for the horizontally lying tube, which I don't know whether it is umbilical arterial catheter because I could not see the going down and coming up, but there is a definite malposition of the umbilical venous catheter. So apart from this, I would like to go through airway. The trachea appears normal. Breathing, the lungs appear normal. And there is and the cardia appears normal. There is no blunting of the costophrenic angles. Bones appear normal. No focal lesions or lytic or fractures. And the abdomen, I could see the stomach bubble and the other bowel shadows. No evidence of any pneumoperitoneum. No evidence of any airflow levels to suggest obstruction. So I'm thinking in terms of a malposition umbilical venous catheter which has gone very high up. I think it has gone through the inferior vena cava, through the right atrium to superior vena cava very high up. I could not make about this horizontal place to this might be another malposition umbilical arterial catheter. And I will inform the findings to the referring clinician for urgent referral. And I would like to do the normal position, reposition the catheters to prevent any further damage. Because this malposition might predispose to thrombosis or any other complications.
Yeah. Are there any other lines and tubes that you probably haven't commented on? So these were external.
Yeah, these were external. There is a VP shunt that is there on the right side. I think it is coming from cranially into the abdomen. Yeah.
Can you see an endotracheal tube?
Yeah, okay. Yeah, I can see. I think it has gone into the right bronchus. Yeah, it has gone below the level of carina, but I couldn't see any collapse of the right lung, any segmental collapse. It has gone beneath the level of carina. Yeah, I think I missed that one. I think these are to be positioned correctly before they do further undergo any other procedures.
Yeah. So yeah, you commented on the umbilical venous catheter, which is too high up, and it's projected over the superior vena cava. So that's abnormal. So this second line was actually, this patient actually had 2 umbilical venous catheters. So this second one, yeah, as you can see, because it doesn't dip down as you would see an umbilical arterial catheter doing. So these were 2 umbilical venous catheters. And this second one is also too high up, and it's actually coiled within the right atrium. So that tip is within the right atrium.
Okay.
Yeah, as you said, the endotracheal tube is too far down, and it's in the right main bronchus. And you can see the lungs as well. What do you think of the lungs?
Yeah, I think there is increased opacifications on both sides. It might be due to the bronchial intubation of the endotracheal tube in the hindsight now. Yeah. And there is decreased aeration due to the bronchial intubation.
Yeah, so this patient, you can see there's bilateral diffuse kind of granular opacification of the lungs, and you can see some ear bronchograms as well. So the lungs are definitely abnormal, slightly of low volume as well. So this patient had respiratory distress syndrome, and you can see that all they've misplaced the umbilical venous catheters and the endotracheal tube. I'm not entirely sure what this line is. I think this was external. But yeah, so we've got 3 misplaced lines and abnormal lungs. So again, you need to, the next step would be to inform the team as soon as possible to let them know of the misplaced lines, and they will need to be replaced, or the ET tube will need to be brought back, withdrawn a couple of centimeters.
Okay.
And yeah, the abdomen, that was fine. You commented on that. So yeah, no. Bowel gas pattern was normal, so there's no pneumoperitoneum. Can comment on portal venous gas or any mottling. Okay.
Yeah, so I've been provided with the frontal chest radiograph of a skeletally immature patient. This is a supine portable radiograph. I would like to quickly go through the sequence. Like the nasogastric tube is noted in correct position with the tip going through crossing the carina and going to beneath the left hemidiaphragm into the stomach. The other main thing is the endotracheal tube, which has gone beneath the level of the carina into the right main bronchus, causing the entire collapse of the left lung. There is complete opacification of the left lung because of the right bronchial intubation of the endotracheal tube. And apart from this, there are few external lying tubes that are seen in overlying the face. and there are no other tubes to be commented upon. Now going systematically through the airway. So this is bronchial intubation. There is complete opacification of the left lung. The right lung aeration is normal. There are no focal or any diffuse lesions. The costophrenic angle appears normal, and the bones show normal density, no focal lesions, no fractures. The visualized abdomen appears normal. There is no evidence of any pneumoperitoneum. So my principal diagnosis here being the right bronchial intubation causing complete collapse of the left lung. So in my routine practice, I will inform the referring clinician of the findings, as this is an emergency, inform the pediatric team for reposition of the endotracheal tube to the above the level of carina to promote aeration of the collapsed opacified left lung.
Yeah, very good. Yeah, so you spotted the findings. So you've got the ET tube in the right main bronchus and the left lung collapse resulting because of that. So good. So you commented on the lines and tubes first. So you've got the NG tube, which is appropriately sited, and the ET tube, which is obviously not. And you can see that there's volume loss on that left side. You can't really see the right heart border. You've got the gastric bubble, which is higher than usual, and that's because of the lung collapse and the hemidiaphragm being pulled upwards. You can see this rib crowding as well, which is suggesting that there's volume loss on that left side. So good. Yeah, you're going to call the team ASAP, inform them to withdraw the ET tube as soon as possible. Good. So yeah, this is just a diagram kind of explaining the different causes of an opaque hemithorax. So it can be due to a variety of things, and what you want to do is look to see whether there's any mediastinal shift, and that will help to figure out what pathology is causing it. So in cases of pneumonia, you won't necessarily get any mediastinal shift. When you're looking at the intercostal spaces, they will be symmetrical on both sides. You might get some delayed blunting of that costophrenic angle, which could be due to infection or pleural effusion. Yeah, so if you, so in other cases, if you get mediastinal shift, you want to see which side it's being pulled towards. So if it's contralateral to the side of the abnormality, so that could suggest an effusion or a large intrathoracic tumor. Other things would be a diaphragmatic hernia where you've got extra contents within the hemithorax. And you can look at the intercostal spaces, so they will commonly be widened when compared to the left side. You'll get, in the case of an effusion, you'll get early dense opacification of that costophrenic angle. In cases of collapse or post-pneumonectomy, you'll get ipsilateral mediastinal shift, and you'll get the opposite. So you'll get narrowing of the intercostal spaces, elevation of the hemidiaphragm because you've got low volume on that side. Other conditions that you can also get this type of appearance would be in pulmonary agenesis, aplasia or hypoplasia, and lymphangitis. So you'll get these narrowing of the intercostal spaces. So this is just something to keep in mind. So we'll move on to case 5. Yeah, so if you want to present this.
Yeah, I've been provided with a frontal chest radiograph of a skeletal immature patient. I would like to go systematically through the radiograph. I think there is the main positive findings. The important abnormality here is the complete opacification of the left hemithorax. With I think there is left hemithorax. There is elevation of the left hemidiaphragm, suggesting volume loss of the left hemithorax. I think there is decrease in the intercostal spaces when compared to the right side, again suggesting decrease in the volume of the left hemithorax. And I could not see the I could not see the cardia separately. The right heart border is also not seen separately. I think I could not right heart border. Yeah, I think there is no significant mediastinal shift onto the right side. The other important negative findings being there is no evidence of pneumothorax, and the right lung aeration appears normal, and going to the right hemidiaphragm appears normal. The stomach bubble is seen beneath the left hemidiaphragm. The visualized bones show no focal lesions or fractures. So the main interpretation being opaque left hemithorax with reduced left lung volume, and I think there is ipsilateral mediastinal shift, as we can see here. And my principal diagnosis will be any collapse might be due to an obstruction at the level of bronchus. Might be. Can I know the age of the patient? I think it is
So this was a chest X-ray done at birth. So this is day 1, yeah.
Day 1, yeah. I could not see the humeral epiphysis. I'm thinking of collapse in a neonate. Yeah, I think foreign bodies, all those things don't come into this age group. Might be some atresia, can be due to an atresia of the bronchus causing complete collapse of the left left lung. The other unlikely causes are foreign body, which doesn't occur at this age.
Yeah.
And I think I would go with atresia as my principal diagnosis, keeping the foreign body at the below the level of diagnosis being very unlikely. I will inform the referring clinician of the findings, inform the pediatric team of the findings.
Okay, good. Yeah, just a comment. So can you see the airway at all, the bronchi?
Yeah, no, I couldn't actually really appreciate. Okay, I could see the trachea in the proximal part, but no, I couldn't appreciate much.
Yeah. Okay, so that was really good presentation. So yeah, you're right. So this was a chest X-ray at birth, so we're not really kind of thinking about kind of foreign body ingestion, but so this patient went on to have a CT, and so this we've got a single image, an axial image through the upper chest. So if you want to just comment on what you can see here.
Yeah, I've been provided with a single axial contrast enhanced CT image in lung window. Showing, I think there are multiple vascular structures in the medial and posterior, that is visceral and paravertebral compartments of the mediastinum on the right side. I think this is the heart. Yeah, I think the heart has fallen behind, and there is a single bronchus that is going on to the left side. The descending thoracic height appears normal. I think this looks more like an hyperexpanded right lung, and there is a complete collapse of the left lung. I think this is compensated hyperexpanded right lung, which is covering almost all of the thorax, and I think there is a complete collapse of the left lung. So I think this bronchus being only the right lung bronchus we are seeing here. And
yeah. Good, perfect. Well done. Yeah, so you're right. So this was you're right. So this is hyperinflation of the right lung, which extends over onto the left side, and that's because this patient actually had left lung agenesis. So you can see that there's a complete absence of a left lung parenchyma. You can't really see it at all. You can't see the left main. I know this is just a single image, but there was no left main bronchus or vasculature associated because there was no left lung. So they had a single right main bronchus, and then the right lung has hypertrophy to fill in that space. So this was left lung agenesis. So you can get agenesis, aplasia, or hypoplasia. So agenesis being complete absence of the lung, the associated bronchus and the vasculature. Aplasia is where you get a blind ending rudimentary bronchus with the rest being absent. And then hypoplasia, you get rudimentary lung and bronchus, but then you get a decreased number of airways, alveoli and vessels that are associated with it. So it'll be much a smaller hypoplastic. So this can be associated with other congenital malformations, especially in the case of congenital diaphragmatic hernia, where you have intra-abdominal contents in the thoracic cavity preventing that lung from developing normally. So good, well done. That was really good. Okay, I don't know. Are we moving on to candidate 2 now, or Azar, are you there?
Oh yeah, I'm there. Shall I present this case?
Yeah, go on. Okay.
Yeah, I've been provided with the frontal chest radiograph of a skeletally immature patient. The most striking abnormality being the complete opacification of the right hemithorax with contralateral tracheal and mediastinal shift. I couldn't see the right heart border separately. There is obscuration of the right costophrenic angle. And apart from this, the left lung, there is a decreased volume of the left lung due to the contralateral mediastinal shift. However, there are no focal or diffuse lesions within the left lung parenchyma, no pleural effusion on the left side, no pneumothorax on the left side. Apart from this, I could not, there is obscuration of the right hemidiaphragm. The left hemidiaphragm is seen clearly, and the visualized bones show no focal lesions or any fractures. So my principal diagnosis being complete opacified right hemithorax with contralateral mediastinal shift. So my principal diagnosis here will be a pleural effusion which is causing a mediastinal shift rather than the collapse which causes an ipsilateral mediastinal shift. So pleural effusion, large pleural effusion causing a contralateral mediastinal shift, or any mass which is causing a contralateral mediastinal shifts. So these are my principal diagnosis. I'll inform my findings to the referring clinician, inform the pediatric team for further discussion. I would like to do a cross-sectional imaging to know the exact cause of the this finding. I would like to compare with previous imaging.
Okay. Yeah, so cross-sectional imaging. Is there, so what kind of modality would you want to do?
Yeah, I would like to do a CT thorax, low dose CT thorax, being a pediatric patient, to know exactly the cause, because my differentials here are a pleural effusion and a mass. I'm thinking of pleural effusion in the first top differential. So before I to proceed further and do any procedure or intervention, I would like to confirm my findings.
Okay, so in children, instead of doing a CT, what other
we can do an ultrasound. Yeah, we can do an ultrasound to know. Yeah, I would do an ultrasound first, and later we can go for cross-sectional image.
Yeah, so we can use ultrasound. It's easy, accessible, and we can assess the pleural spaces in children quite well. So so this patient went on to have an ultrasound, so we've got an image here.
Yeah, this is the transaxial image of the ultrasound of the same patient. I think the image in the right side being the liver, and there is a right hemidiaphragm, and there is pleural effusion with collapse of the lung. I think there is a fluid in the right hemithorax. I think this confirms my first differential diagnosis of pleural effusion being the cause of the opacification and causing the contralateral shift.
Okay, and do you think this is just a simple pleural collection, like simple pleural fluid?
I couldn't see any septa. There's a collapsed lung in it, but I couldn't see any septa or any loculi. I couldn't appreciate on this. Yeah, there is a.
What do you think of this?
Yeah, I'm thinking that being a mass, and that being a mass or causing a reactive pleural effusion here. Yeah, I would like to.
Okay. Yeah. So I'll just go through this. So you, I'll just go back to the chest. Yeah. So you commented on all the findings. So you've got opacification of the right hemithorax with mediastinal shift and tracheal deviation. As you said, your differentials of pleural effusion or intrathoracic mass are correct, and then you'd go on to do an ultrasound to assess that further. So with this patient, so this is, you've got the liver here below, and then you've got this heterogeneous kind of pleural collection. So you've got this kind of tongue-shaped collection with no air bronchograms to suggest that it's a lung or that it's aerated, and that is something that we would see in consolidated lung. And you've got some fluid in the dependent area as well, which is evidenced by the low-level echoes here, and you can see the liver here, so you can compare the echogenicity. Obviously, this is seen better dynamically when you're performing the scan, because you can see the movement of the fluid echoes, and you can see the collapsed lung fluttering amidst the fluid as well. So this was an empyema, and so it was a pleural collection, empyema.
Okay.
Yeah, good. So I'll just go through just the guidelines from the BTS on pleural on an empyema. So firstly, you want to take frontal radiographs and then do an ultrasound to confirm the presence of a pleural fluid collection. It's also done to guide the drain placement as well. And these guidelines basically kind of tell you when to do a CT. So for example, if the surgeons are considering a thoracotomy, or if you've got complex septations within the collection or echogenic collections, which are seen on ultrasound, that's when you would go on to do a CT. But yes, you're right. So the differential would be a mass as well, as you said. It's sometimes difficult to tell and confirm that on an ultrasound. Good. Okay, so we're going to move on to candidate 2. Thank you, candidate 1. You did really well.
Thank you very much. If no other candidate is there, I will be happy to present again.
Oh, okay.
I'm candidate 2 here.
Yeah, I can hear you. Hi, welcome. Do you want to present this case?
Sure. So, okay, this is a frontal radiograph, chest radiograph of a pediatric group patient. So, okay, I can see that the AETT tube is above the carina and is at the appropriate position. There are some other external lines as well. I think these are the electrocardio lines. There's another tube. I think it is external to the patient at the right upper neck until the hemithorax.
That's external,
external. So other than that, okay. So I'm going through the airway. So airway seems central trachea, and I can see both bronchi and the lungs. Okay, there is homogeneous opacity over the right middle and lower zone, which are obscuring the right heart border as well as the right hemidiaphragm. So they might have some small right pleural effusion because of the blunting of the right costophrenic angle. So I don't see the right intercostal space seems still preserved. I think that the right lung volume is still preserved. Okay, so moving towards the left lung, the upper zone appears clear. However, there's some heterogeneous opacities over the left lower zone. I can't really see the left hemidiaphragm is not well outlined. Okay. Okay, so I'm reviewing at the bony thorax. It seems unremarkable. The heart appears still because it's supine, so I think it's still within normal limit. Okay, so I don't see any pneumothorax in this radiograph. So in conclusion, I think this is clinically unwell patient which is intubated and showing bilateral lung infection, more prominent at the lower lobes, and also could affect bilateral lower lobes and also right middle lobe.
Good. So you picked up all the findings. So you've got the ET tube, which is in a good position, and you've got this patchy airspace opacification within both lungs, mainly in the mid to lower zones. And yep, the right heart border, both hemidiaphragms are obscured. So there's definitely some consolidation going on here, plus or minus pleural effusion. Yep, so this patient went on to have an ultrasound scan of both lungs. And what can you see here?
Okay. These are the selected images of ultrasound of this patient. For the left side, I can see there is hepatization of both visualized lower lobes. Yeah, and also I can see echogenicity within it could represent the air foci.
Mm-hmm.
I don't see any pleural effusion. So this confirms the findings of bilateral lung consolidation.
Yeah, good. So these images are demonstrating bilateral consolidation, as you rightly said, and yep, this is, you've got hepatization. Yeah, so consolidation on ultrasound, you get this hepatization and air bronchograms of the lung. So you can see this echogenic branching structures, which are the air bronchograms. And if you look at the echo texture of the lungs, it looks very similar to the liver, hence the term hepatization. And yeah, so that was seen on both lungs in the previous images. And here on the right, you can see that there is also a trace, small pleural effusion as well, adjacent to that consolidated lung. Good. Well done. Okay, so this is just a slide just talking about normal lung ultrasound. So you're looking for A lines, which demonstrate the normal appearance of the lung surface. So what they basically are, you get these echogenic kind of gradually fading horizontal lines below the pleura. And they basically represent the repetition artifact of the parietal pleura. And it just suggests that there's air beyond the pleura, which would be normal. And the distance is basically the same as the distance between the skin surface and the pleural line. Also, another point I did say that would suggest that it's normal, but you could also see these A lines in the cases of pneumothorax as well, because it basically just suggests that there's air beyond the pleural surface, and you'll get a similar appearance in that as well. It's better seen on a linear probe, but here you've got both appearances in the linear and curvilinear probe as well, where you get similar appearance. So that's the A line seen on normal lung ultrasound. Okay, so we'll move on to case 6. We'll continue actually.
So this is a frontal chest radiograph of an pediatric group patient. I can see that the airway is deviated to the right. Okay, and there's a total white out of the left hemithorax. I cannot appreciate any obvious left main bronchus. So, and the left heart border and the left hemidiaphragm are both obscured by this homogeneous opacity. Okay, and the intercostal space is still preserved over the left side. Okay, mediastinum shift to the right as well. The right lung is clear. The right hemidiaphragm is unremarkable. The bony thorax is unremarkable as well. So in conclusion, the left white out lung could represent, most likely to represent left pleural effusion. massive pleural effusion causing the mass effect, causing right mediastinal shift. So my differential would be a lung mass, a left hemithorax mass causing this. So next step, I will convey this message to the referring physician, and I will proceed with ultrasound to confirm the finding.
Okay. So this was the ultrasound which was done.
So the ultrasound shows that there is presence of left pleural effusion, which confirm the finding, and also there is atelectasis of the left visualized lung. There is I think there's also a collapse of the lower portion of the left lung, which you see in the lower portion of this ultrasound instead of the mass.
Okay. Yeah. Sorry. What did you describe this as?
Yeah, I mean, I'm not sure because I cannot see any bronchogram within it, a bronchogram. So I'm thinking it could be a total collapse of the lung lobe as well. Differential would be a mass. Maybe a dynamic ultrasound could help to see differentiate between these two.
Okay. Okay. Yeah. So we can see that this is the normal lung, and then you've got the anechoic fluid here, which is the pleural effusion. But then you've got this this extra bit here, which is quite heterogeneous and doesn't really have a similar echo texture to the lung that's adjacent to it. So this was a mass that was seen within the thoracic cavity, and you can see it's quite heterogeneous. There's kind of rounded cystic spaces which aren't really tubular, and then you've got these kind of curvilinear areas of high echogenicity as well, and it's quite rounded, well defined, and it's separate to the lung. So this was a mass, and this patient went on to have a CT scan to clarify that further. What can you see here?
Okay. So these are selected axial images of the left of the thorax. They are contrasted scan in the portovenous phase and the mediastinal window. So I can see that the presence of a huge mass in the left hemithorax, and it appears heterogeneous with some and also mainly the hypodense areas. I can see some calcifications within it. Okay, the lung, visualized left lung is atelectatic collapse, and there's presence of the mild pleural effusion over the left hemithorax. It causes mass effect and pushing the mediastinal structure to the right. So in press, okay, and okay, this is a huge left lung mass.
Yeah.
So my differential diagnosis would be the left lung neoplasm. And okay, I forgot to mention about the bones. The visualized bones appears unremarkable. There's no.
Yeah, don't worry about them. Yeah, that's fine.
Differential would be left mediastinal mass, or most likely from the posterior or medial mediastinum.
Yeah. Okay. Good. So this CT is, you can see this large heterogeneous mass filling the left hemithorax, and you can see, as you said, the collapsed lung. You can see here with the air within the bronchi there, and it's causing contralateral mediastinal shift. And then, yeah, there are areas of high density as well. So this was a contrast CT. So I think we've got some vascularity within it. And you can see there's they've inserted a drain as well, which you can see at the lateral aspect of the chest extending medially. Yeah, so this was a large mass. And you can see the low attenuation, which represented areas of necrosis centrally. So this was a pleuropulmonary blastoma. So these are quite rare, but most of them occur between the ages of 0 to 2 years old. And they have a lot of associations, particularly with a CPAMs, other gene mutations, multilocular cystic nephromas, Wilms tumors, and they are classified into 3 types with an increasing order of malignant potential. So type 1, which has the best prognosis, is the cystic type. So we did see some areas, cystic areas on the ultrasound on that one, and then the type 2 is the mixed type, which is a slightly worse prognosis. And then the type 3 is the solid type. So these are usually right-sided, pleurally based. You don't tend to see much chest wall invasion or calcifications within them. But yeah, as we saw in the chest x-ray, they usually present with a whiteout of the lung with contralateral mediastinal shift. Sometimes they might be associated with the pneumothorax. And as we saw with the mixed solid cystic masses on the ultrasound, it usually presents with a heterogeneous mass, and sometimes you might also get a pleural effusion as well. So yeah, well done. That was a hard one, but you picked up that. You mentioned the right differential, so you're thinking about pleural effusion, intrathoracic mass, and you'll go on to clarify that further with doing an ultrasound of the chest.
Moving. Can everybody hear me? Can you see a laser?
Move your arrow, Divya. Yeah. So we can see the laser pointer.
Yeah. Okay. Good.
Yeah.
And I hope my connection is clear, but please put in the chat if you can't hear me well, or if I break up.
I can hear you clearly.
Okay. Thank you. So just a brief introduction on what we are going to see in the next few cases. So we just saw a few cases which are based on whiteout of the lung, which is like a opaque hemithorax. And the next few cases are going to be about asymmetric lung densities. So as you know, normal lung, it would have air, and you should normally see it in a gray-black sort of appearance. It should not have any white or gray, like more white densities. But you can have asymmetric lung densities where the lung is having air, but there is still a bit of asymmetry, and that can be due to respiratory causes, especially when you have a contralateral mediastinal shift, and you see that there is an asymmetric density. One lung is more hyperlucent, and you have a contralateral shift, and that can be due to foreign body aspiration, and this can look normal on a single inspiratory chest X-ray. So if the history is really suggestive, you need to be very careful and think about doing inspiratory, expiratory X-rays if the child can cooperate. Additionally, mucus plugging can also cause asymmetric lung density and air trapping, and usually these patients would have a background of asthma, or they would be on ventilation, and that leads to mucus formation and plugging inside the airways. You can also have congenital lobar emphysema, which is a pediatric specific condition which causes asymmetric lung density and a hyperlucency. Or sometimes you can have tracheobronchial narrowing due to various reasons, which can lead to this. You can have respiratory causes without a mediastinal shift, and that is seen in causes of unilateral hypoplastic lung. One lung is usually having a lower volume, not a complete agenesis like we saw in the previous session, but it's just a lower volume or hypoplastic lung. There is a condition which is called congenital veno-lobar syndrome or scimitar syndrome, which is a lung, hypoplastic lung, which is associated with a partial anomalous pulmonary venous return. You can have constrictive bronchiolitis, which is also called Swyer-James syndrome, where you can have a hypoplastic lung. There are cardiac causes which can cause asymmetric lung densities. It's not commonly seen in exams, but you can see it in post-cardiac surgery when you have had when the child has had a PT shunt, and very rarely in pediatrics you would have pulmonary embolism, but it does happen, and that would also lead to a hyperlucency of the lung. So what are the causes of tracheal bronchial narrowing or stenosis or compression? So you can have obstruction within the lumen, and that would mostly be foreign bodies, especially in toddlers. They would ingest or inhale or aspirate things. You can have mucus plugs. You can also have blood clots, and sometimes there are tubes which can get broken and occlude the airways as well. Within the wall, you can have abnormalities of atresia or stenosis. You can have tracheobronchial malacia, which is abnormality where the lumen collapses. And you can also have inflammation or fibrosis, which can cause narrowing. And tumors are rare in children, but you can have carcinoids. And outside the lumens, various causes of obstruction can be due to lymph nodes, or if they have congenital cysts or mediastinal tumors, which are compressing the mediastinal trachea, or you can have vascular rings or slings, which we'll also look at, and sometimes aneurysmal aorta, which is rare, but you can have aneurysmal aorta with some connective tissue diseases, or children with who have like collagen vascular disease as well.
Divya.
So yeah.
Divya, sorry to disturb, but there's someone is annotating on the screen, so that yellow line. So are you able to switch off the annotations for everyone? It should be on the settings at the top, and it says kind of turn off annotations.
Disable annotations.
Yep, and then if we can remove that annotation as well.
How do I remove that?
Is there an option there to remove? I think that it says clear annotation, and then just disable.
I've disabled the annotations.
Yeah, it's just there's that yellow line there, so we just need to get rid of that. Should be something that says clear annotation.
Oh yeah, clear all drawings. Yep. Is that?
Yeah, that's worked now. Great.
Cool. Mm-hmm. Yeah, sorry about that. Is it candidate 2 still? Do you want to present this one?
Okay, sure. Hi. This is a frontal chest radiograph of a pediatric group patient. So the airway is central. I can see both main bronchi clearly. The lungs, okay, I can appreciate some patchy opacities over the right lower zone, which are next to the right heart border. The right heart border is, however, still well demarcated, the right hemidiaphragm as well. There is some narrowing over the right intercostal spaces. And the heart is normal in size. And sorry, okay, I'll just continue with the lungs. So the lungs, I don't see any pneumothorax or pleural effusion. The left lung is clear. Okay, I'm going through my review areas, the apicals, the hilar regions, the retrocardia, the subdiaphragmatic spaces are clear. So the visualized bony thorax is unremarkable. So in conclusion, I would think this is right middle lobe opacities at the in the right lung. So differential would be an infection. Yeah, I would correlate clinically, and if there's any previous radiograph to compare, to do some comparison. So, yeah. So in conclusion, it's a right lung pneumonia involving the right middle lobe.
Okay, so that's good. That's well done, because you are saying the right lung is the abnormal one, and you are thinking that this is a possible consolidation.
Yes.
Okay. So can you see my laser pointer?
Yes.
So usually, when you can you appreciate a very subtle asymmetry between the lung densities, like a diffuse.
Yes.
Okay.
Quite subtle. Yeah.
It's very subtle. I agree with you. But so if I say this child presented with acute wheezing, would you like to do something further?
Okay. Wheezing. So okay. So maybe okay expiratory.
Choking. Yeah. Yeah. That's good. So now you can actually appreciate there's quite a asymmetry. You can describe that?
Yeah. So okay. So in the inspiratory radiograph, the lung densities appears quite symmetry, and relative to the left side, on the right side, the expiratory radiograph, the left lung is still preserved, is still relatively more loosened than the right lung, and the left lung volume is still more than the right lung. So in this case, I would suspect foreign body aspiration.
Yeah, correct. So in toddlers, the history can be very misleading. You would never see, sometimes they have not witnessed the child has eaten something, and probably it has gone into the trachea, and they're prone to picking up peanuts and stuff like that and putting that in their mouth. So you always have to worry when you have an audible wheeze in the history. And so you can clearly see between the inspiratory and expiratory, the left lung volume has not normally reduced. So in expiration, your lung volume would reduce, and the lung would become a bit more white when it's in expiration. So a normal expiratory lung, this is another pitfall of a expiratory lung radiograph. So if you have an expiratory lung radiograph, you are prone to see prominent perihilar markings. So you would tend to overcall them. So always be wary of an expiratory radiograph. And but in case of this, you can see there's a clear increased hyperlucency of the left lung on expiration because there is air trapping. So there's air which is coming into the left lung, but because of the foreign body which is lodged, there's like a one-way valve mechanism, and air is not able to get out. And that leads to like air trapping within the lung, and that leads to a hypertransradiancy of that side. So in this case, this was a foreign body, and in case of foreign body inhalation aspiration, this is an emergency. So you have to immediately call the referring clinician, and they have to go ahead with a bronchoscopy and remove the foreign body. And sometimes if it is clinically suspected, they wouldn't even wait for a chest x-ray, and they would just go ahead with a bronchoscopy and remove the foreign body. On chest x-ray, in advanced cases, you can have a complete lobar collapse, and but in cases where it's a partially occluding one and it's causing that sort of valve mechanism, it can lead to air trapping and thus differing lung radiolucencies. In the obstructed lung, as you saw, there would be no change in the volume, and the mediastinal shift, if it is air trapping which is causing a shift, it would be towards the contralateral side. And if there is a chronic wheeze or a recurrent persistent infection, a CT is better, because in case of partially occluding foreign bodies which are chronically present, they may not present with acutely, but they would present with recurrent persistent infections, and that is something that you would see on a CT. And remember, toddlers, they would commonly ingest, inhale, and you would not have a clear history. So if there is any suspicion, even clinically with an audible wheeze or a stridor or something, you would want to just go ahead with a bronchoscopy. So this is just a companion case, and this was a 2-year-old, and here you are able to appreciate it a bit better. So you can see that there is hyperlucency of the right hemithorax, and this was a child who was choking and was still wheezing, and they did the x-ray, and you can see how much there's a difference because of the air trapping. So next case. Is it candidate 2, or should we go to, is there a candidate 3?
No, we can move to candidate 4.
Yeah, sure. Candidate 4, if you would like to take this one. Hello?
If candidate 4 is not there, we could move back to candidate 1.
Yeah,
Are you still there?
Yeah.
Okay, so yeah, if we'll go back to candidate 1 then.
Do you want to just present it how you would in a chest radiograph?
Yeah, I've been provided with a frontal chest radiograph of a skeletally immature patient. I would first discuss the tubes. The endotracheal tube is above the level of the carina. The nasogastric tube goes into below the level of left hemidiaphragm. I think there is one more overlying tube over the lower thoracic vertebra. Couldn't make out what it is. Now going systematically through the lungs, I could see in evidence of lucency in the right crostophrenic sulcus, and there is increased bronchovascular markings of the right lung. The right hemidiaphragm is seen clearly, and there is another lucency in the right paramediastinal region. Now coming to the left side, the left lung shows normal aeration, normal bronchovascular markings. Now coming to the cardia shows normal density. The left hemidiaphragm shows normal density. Now coming to the bones, there no evidence of focal lesions and fractures. So my main interpretation is the lucency noted in the right lower zone involving the right costophrenic angle, and another lucency in the right paramediastinal region. So may I know the clinical history of the patient?
This patient is ventilated in ICU, and this is a chest X-ray because he's developed new oxygen requirement, which is increasing his oxygen requirement.
Okay,
rather.
yeah, I'm seeing here there is increased granularity of the both lungs. I'm thinking in terms of a surfactant deficiency, and with the ventilation, I'm seeing this might be either some small pockets of pneumothorax or pulmonary interstitial emphysema in the right lung and increased granularity. So this is my principal diagnosis, either pneumothorax or pulmonary interstitial emphysema. So I inform the findings to the referring clinician, inform the pediatric team, and compare with the previous radiograph to see the changes.
Yeah, excellent. That's really well done. And this is the same case over the next few days, if you want to describe.
I think same case. I think there is increase in the pneumothorax. I can see the lucency increase in the right upper zone. Again, there is that increased pulmonary interstitial emphysema of the right lung, and the granularity is still there in the left lung. I think the full-blown pneumothorax is seen in the right-sided radiograph, and they have kept an intercostal drain tube for the same. I think the lines positions, there's no malposition of any of the lines. So I think this is a pneumothorax complicated due to pulmonary interstitial emphysema, which is a complication of ventilation of a surfactant deficiency disease.
Okay. The children who are on ventilation and with positive pressure ventilation, pneumothorax can happen even without an underlying lung disease. And in this case, I think it is related to their ventilation. But yes, it's very correctly identified on the first radiograph itself. It was a pneumothorax, and the clue there was the deep sulcus sign, as you said, along the right lower zone. And you have to be very careful in any patient with new pleuritic chest pain or unexplained breathlessness. Always look carefully for a pneumothorax, and always double check the lung epices as well as the costophrenic angles. And the three cardinal features, as you know, of a pneumothorax is when you have a clearly defined line, and that is the visceral pleura, which you can see in profile, and it will parallel the chest wall, and the upper part of the line would be curved at the lung apex. So that's why I always check the epices. The overlapping ribs can be a problem, so you should always make sure to go through each intercostal space and make sure that you look between the ribs, and if there's any absence of lung markings lateral to it, that is, there are no vessels, then you would suspect a pneumothorax. And you must always hunt for the evidence. Don't just briefly look at an X-ray, otherwise you will miss a small pneumothorax. But excellent, that was really well done on the on that case. And another case, if you just want to describe.
Yeah, I've been provided.
Sorry, I just wanted to say candidate 4 was actually present, but we couldn't hear them.
Should we continue with this one, and then after the next case, I'll move to candidate 4?
Yeah, okay.
Yeah, okay. I've been provided with a frontal chest radiograph of a skeletal immature patient. The most striking abnormality is the increased lucency of the left hemithorax. There is a pneumothorax with the collapsed lung. And apart from this, there is a continuous diaphragm sign, which is above the level of the right and left hemidiaphragm below the cardia, keeping in with a pneumomediastinum. I think patient has both pneumothorax and pneumomediastinum. There is no contralateral mediastinal shift. The right lung appears unremarkable. No pleural effusion, pneumothorax on the right side. There is no pneumoperitoneum. There are no focal lesions or fractures in the bone. So principal diagnosis here being a left pneumothorax and a pneumomediastinum. I would inform the findings to the referring physician, urgently inform the pediatric team and compare with the previous imaging.
Perfect. That's really well done. Additionally, in this case, there's also increased perihilar bronchial wall thickening, which you can really see well on the right side, although the left lung is collapsed because of the pneumothorax. So this is actually a case of viral triggered bronchiolitis, and in case of bronchiolitis, when it's severe, they can get pneumothorax and pneumomediastinum as well. So really well done. That's excellent. So candidate 4, are you able to present this case? Are you there? I can't.
Yeah, so they are unmuted, but we just can't hear them. So I think they might be having some technical issues. Yeah, because they're unmuted, but we can't hear anything. Okay, fine. We might just have to continue with candidate 1.
Oh, shall I continue or?
Yeah, you can. Feel free.
Yeah.
Sure. Yeah.
Yeah, I've been provided with frontal chest radiograph of a skeletally immature patient. The most striking abnormality is the air lucencies occupying the left hemithorax, which are going towards the right hemithorax and causing the contralateral mediastinal shift. I think I would go, and the other important finding is the nasogastric tube is going into the the left hemithorax. The endotracheal tube is optimal in position. So these, and there is decreased, massive decrease in volume of the right lung. I could see the right hemidiaphragm. So to summarize my findings, cystic lucencies like pertaining to the bowel in the left hemithorax with non-visualization of the left diaphragm, contralateral mediastinal shift, and the coiling of the nasogastric tube, keeping in favor of congenital diaphragmatic hernia. So I would inform the findings to the referring clinician, inform the pediatric team, and I would compare with the antenatal and findings if there was there in the antenatal scan also, and compare with previous image.
Yeah. So you're right. This is a congenital diaphragmatic hernia, very well described. And usually they are picked up on antenatal imaging, and it is usually a postnatal X-ray which is done. But this is a CDH, and just to show another patient with the same diagnosis. And if you want to describe.
Yeah, I've been provided with frontal radiograph of an immature patient. The striking abnormality being the nasogastric tube going into the left hemithorax, no visualization of the left hemidiaphragm. There's continuity of the bowel loops going from the abdomen into the left hemithorax, causing contralateral mediastinal shift, and decreased right lung volume. And there is a pneumoperitoneum. I could see air beneath the right hemidiaphragm, and the visualized bones appear unremarkable, no fractures or any focal lesion. So my principal diagnosis being congenital diaphragmatic hernia with contralateral mediastinal shift and pneumoperitoneum. So I'll inform the findings to referring clinician, inform the pediatric team, and compare with previous imaging.
Okay, this child also has pneumothorax because they are on ventilation. So it's actually outlining here as well. So they are prone to have hypoplastic lungs, and that makes them more vulnerable when they're compressed to get pneumothorax, and then that would also track down into the peritoneum because of the hernia, and that's why you also have the air within the peritoneal cavity. But it's the lungs which are underdeveloped, which increases the risk of pneumothorax, and the air then enters the peritoneal cavity as well. So yeah, really well done. It's the same congenital diaphragmatic hernia, and usually they are left-sided, as you saw. They are Bok-Talack hernias when they are left-sided, and the differential diagnosis would be a congenital pulmonary airway malformation because of the cystic appearance, and the treatment is usually surgical repair. Obviously, it is if it is possible in utero, they do it. But this helps in the management of pulmonary hypoplasia, and these patients, these children, babies, they often require ECMO support because the lungs are really hypoplastic, and usually they are not able to ventilate them sufficiently, and they end up being on ECMO support. The late onset hernias, they can also occur in group B stepped pneumonias, and if it is a right-sided hernia, then you can have the herniation of the liver rather than the bowel loops. And fetal MR can confirm this diagnosis, especially when there is antenatal ultrasound and in equivocal cases. And fetal MR is now used to even quantify the lung volumes, and that helps in management to decide when to do the surgery, because they want the lungs to develop enough before doing the surgery. And these cases, they have significant mortality, and they're also associated with other system abnormalities, including neurological abnormalities, GI, GU, and cardiovascular abnormalities. So this is a very important condition to be aware of. So candidate 4, are you here now?
Yes, can you hear me?
Yeah, I can. Do you want to press them?
So sorry for the previous. So the frontal radiograph of the skeletally immature patient now shows that the left hemithorax has got several lucences within, and the entire right hemithorax shows several lucences within, and there is a lung architectural distortion. I can see a radio density, small nodular radio density at the level of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10th vertebral pedicle. The trachea, visualized trachea appears normal. However, I cannot see the right bronchus. The cardia has almost occupied the entire left hemithorax, and the claustrophrenic angles on the both sides are normal. Based on the appearance, my differentials would be congenital pulmonary airway malformation and type 3, I would say. I would like to discuss this with the referring clinician and go for a cross-sectional imaging to check the diagnosis.
Perfect. That's really well done. What makes you say this is CPAM and nothing else?
I would have gone for a herniation of bowel contents had it been on left side and had seen a diaphragmatic discontinuity. Since the entire of hemithorax is basically not maintaining its normal architecture, I cannot think of any other differentials in this case.
Perfect, no worries. And what cross-sectional imaging would you do?
CT chest?
Just non-contrast?
Yeah. No, with contrast.
Okay, yeah, well done.
To see the vascularity too with the findings.
Yeah, no, really well done. So I'm giving you the selected CT images of the same patient.
Okay, so the cornal, sagittal, and axial reformat of the contrast enhanced CT chest of the same patient now shows that I have got the same lucences here, and although there is a aplasia of the there is a hyperplasia of the left lung and ipsilateral mediastinal shift, and I'm not able to make out the well-formed right pulmonary artery or the vascular supplies, although I can see some vessels there, and the bronchus bronchial supply appears normal to me, but distally in the lung I cannot see the well.
That's okay. You can
Aeration.
just describe what you see. That's fine.
So I see multiple variable size lucences, conglomerate lucences in the right hemithorax, and an underdeveloped vasculature to the right hemithorax. So again, my differentials would be CPAM.
Okay. No, that's good. The CT just confirms what you were suggesting on your on a radiograph. So there is like multiple cysts of different sizes, and you can see the largest cyst does look fairly big, and it's more than 2 centimeters.
Yeah.
So this is just a congenital pulmonary airway malformation, and you would see on chest X-ray, as you said, you can see cysts with or without mediastinal shift, and depending on the size of the cyst, you would say whether what type of it is. Modified Stalker CPAM classification is used, and it is dependent. It is dependent on the size and the cyst. So the type 0 is incompatible with life, while 1 is the most commonest type, which is in more than 65% of the cases, and you would have large intercommunicating cysts, as we saw. And the type 2 has got the smaller size cysts up to 2 centimeters, and 3 is usually a solid lesion with very, very tiny cysts, and that type 3 will have a poor prognosis, while the 4 has got large cysts, and the type 4 CPAM is the one which can be a precursor of pleuropulmonary blastoma. And usually you do surgery for the large lesions, especially if they're causing mediastinal shift and are symptomatic, and they can be infected. So even if they are smaller but they have frequent infections, they would resect the lesion. And congenital pulmonary airway malformations, they are just early airway maldevelopment that leads to cystic and non-cystic lung changes. You have to be careful, they can be hybrid. So hybrid lesions are those who have additional features of sequestration. So they can have a systemic arterial supply along with the cystic spaces. So that's why we would always do a CT chest with contrast. And always make sure that when you do the CT chest with contrast, you extend up to the mid liver or edge of the liver, because you don't want to miss arterial supply, which sometimes can come from the celiac axis or from the SMA. So always do CT chest with contrast. And CPAMs, usually they are supplied from the pulmonary artery, and the drainage is to be pulmonary vein. There's not, they can communicate with airways, and that is the reason why they can get infected. So CT is always the modality of choice to further evaluate. So this is just showing the differences between the CPAM and the CDH. So as you said correctly, in the CPAM, if you see the dome of the diaphragm, you would not think of a CDH, while in a congenital diaphragmatic hernia, you would lose the normal ipsilateral diaphragm, and you would see multiple air-filled bowel loops which are occupying the left hemithorax. And mediastinal shift is much more seen with CDH, and CDH is also much more prone to cause lung hypoplasia, and that's why this is actually a much more difficult condition to treat and manage. Case 11.
Am I taking the case?
Yeah.
Oh, okay. So again, I am provided with the cornal reformation of the contrast enhanced CT chest of the skeletally immature patient and an axial section in the soft tissue window. In the left hemithorax, I can see differential prominence of the vasculature, and over the left diaphragm, I see an opacity with an arterial supply arising from the descending thoracic aorta, systemic arterial supply, and in the lower lung sections of the axial CT of the abdomen shows that the supply is from the aorta of the opacity. So based on the appearance, my differential would be sequestration. And I would like to discuss this case with the referring physician and report it to the consulting pediatrician for further management of the sequestration.
Yeah, perfect. Really well described. So this is actually just a pulmonary sequestration, and sequestration is a non-aerated lung lesion, and they are commonly seen in the left lower lobe, and they have arterial supply. So in this case, you can see the systemic arterial supply is from the supradiaphragmatic aorta here, and in this case, there was venous supply to the azygos via a tortuous vein. So the drainage was also to a systemic venous system. The sequestration is just a mass of lung tissue which gets disconnected from the bronchial tree and then derives the blood supply from systemic vessels. It looks very much like a collapsed lung in terms of the enhancement, but you would definitely have to look for the systemic arterial supply. There are two types: intralobar, which is more common, and that would have a pulmonary venous drainage, and extralobar, where you would have a systemic venous drainage to the azygos or portal venous systems. The chest X-ray will be very difficult to pick up, or they can appear normal because the opacity is usually basal, and on ultrasound they look like homogeneous hyperechoic masses, and you can sometimes see a feeding artery on ultrasound as well. These abnormalities can also be picked up antenatally on ultrasound and subsequently on fetal MRs, but CT remains the most sensitive modality to evaluate the small feeding vessels and arteries. So that's why that's the modality of choice. And just to show the example of the hybrid lesion that I mentioned earlier, you can have a cystic pulmonary airway malformation, and that can also have arterial supply here, which you can see from the celiac axis with pulmonary venous drainage into the pulmonary veins. So this is the reason why you always have to image lower down until the at least till the L2 vertebral level. So you include the abdominal aorta because you can have systemic supply even from the branches of the aorta. Candidate 4, do you want to go ahead with this one as well?
Yeah, please. So the frontal radiograph of the skeletally immature patient shows a well-positioned nasogastric tube and few outside oxygen, few leads on the outside. And on the right hemithorax, I see irregular lucency occupying the right mid and lower zones, and but I can see the vessels through them, and the costophrenic angles, cardiophrenic angles appear normal. The aortic silhouette appears normal. Based on the appearance, my differentials would be of an air trapping in the form of lobar emphysema, or the differentials of I do not see any vascular abnormality to say is there any scimitar syndrome, but I'll put my differential of congenital lobar overinflation, or it could be due to post-infectious bronchiolitis, it could be Swyer-James. I would like to discuss with the referring clinician, and if possible, go for a cross-sectional imaging.
No, you would definitely go for cross-sectional imaging. That's really well described. But do you think this lung on the left, whether it's increased volume or
And on the left lung, I see some tube coming from outside. Is there a drainage tube on the left side? I can see deep sulcus sign.
No. On the right side, you described it perfectly. But do you think that is increased volume, or like you mentioned that the differentials were Swire James, like post-operative bronchiolitis? But do you think that is increased volume, or does that look like hypoplastic or?
It looks to me of an increased volume.
Yeah. So do you want to look at the CT and then?
Yeah, please. Okay, so contrast enhanced CT chest sections in the lung window in the I guess see on the right side there is an opacity on the right side with a vascular supply to it from the I'm having a hard time to describe that finding. Definitely there is an increased volume of the right hemithorax, and
Yep.
Yeah.
No, that's absolutely right. I'll just describe this again for you. So on this radiograph, this is a 3-week-old baby, and you can see that there is lucency and paucity of bronchovascular markings with hyperexpansion in the right mid-lower zone. So the thing that you were thinking was congenital lobar overinflation, which is actually one of the main differentials here. And always remember that when there is an asymmetric lung density, the lung which has got a paucity of vascular markings is the abnormal lung. So when you look at the CT, you can see that the hyperinflation of the right middle lobe is there, and you can see there's a paucity of lung markings when you compare it to the normal left lung. So in asymmetric densities, look for the vascular markings, and if there's a paucity of vascular markings, that's where your money lies. That's where the abnormal lung is. So this is a congenital lobar overinflation, as you said, and it is involving the right middle lobe, which is hyperexpanded. And additional findings are just there is dependent atelectasis in the right upper and lower lobes, but that is probably related to them having the scan under GA and having the ET tube in. So congenital lobar emphysema is again the differentials would be CPAM, but CPAM would be more cystic, and the differential which is very difficult is a bronchial atresia. Because you would expect a similar sort of a segmental or lobar hyperinflation when you have bronchial atresia, but in bronchial atresia you would see the blind ending of the atretic bronchus, and there are no features of this on the X-ray or CT. And this case also had additional absent pulmonary valve syndrome. And in congenital lobar emphysema, it is mainly a bronchial abnormality, and that leads to lumen obstruction, and this leads to a sort of a check valve mechanism, just like how it happens in a foreign body. So you get progressive hyperinflation of that affected lobe, and you would see this as a hyperlucency and overexpansion, as we saw on the chest X-ray, and that may cause a mediastinal shift. And it most commonly affects the left upper lobe, followed by the right middle lobe, like we saw in this case. And the treatment is surgical lobectomy, as these patients, they can develop a respiratory distress. So case 13.
Yeah, again, the frontal radiograph of skeletally immature patient shows well-positioned nasogastric tube and a mediastinal shift towards left due to a hyper expanded right hemithorax, where I can see differential lucencies and opacities. The lucencies have got it looks to me as it's not bowel. I cannot demarcate the diaphragmatic outline. There is a component of effusion with air in the right hemithorax. And also the right bronchus is narrowed than as compared to left. Um, um, I would like to, yeah.
Yeah, what
I'd
would you
like
like
to
to know?
I'd like to perform a contrast enhanced CT test of the patient, if
Okay,
possible.
would you not want to know why they have presented or what the history is, just so that you can justify a CT?
Yeah.
Sure. So this child is 13 months old, unwell for 3 weeks, has cough and fever, and reduced air entry on the right chest. And the question on the thing was query congenital diaphragmatic hernia. But with that history of cough and fever, do you still think it's CDH or?
The lucences appeared to me in the first impression as that of bowel, but I do not see the communication of the bowel lobes with that of the abdominal contents, and even the NGT tube is positioned well. So there lies the dilemma between like to designate it as a CDH or not.
Correct.
First impression was for a CDH only.
Okay, so you would like to do a CT with contrast?
Yeah.
So this is limited axial CT, and then I also have coronal in soft tissue. And let me know if you want to go back.
So the coronal shows that it is definitely not CDH, and I can see the diaphragmatic outline well, and probably the lever with the vascular markings. What I can see now is that there is a large opacity and effusion with internal air lucences within. And I can see the collapsed right lung in the hilar region. And the vascular supply to the lung and the bronchus are not that well defined. So basically, then there is atelectasis in the left lung. I'm not able to reach to a differential based on the appearance. Is it bronchial atresia?
Okay, if this was an adult patient, what would you think? With cough and fever.
Infection leading to hydropneumothorax, buildup of with consolidation showing cavitation within.
Yes, so this is actually necrotizing pneumonia with cavitation. And if you see on the contrast enhanced CT, this is actually, my laser is not moving, unfortunately. But there is enhancement of the pleura. So this is actually like an infected pleural collection, and the lung, as you rightly said, part of it is collapsed, which you can see is well enhancing along the right lower lobe. And but the whole of the upper lobe has formed a cavitation, and you can see a air fluid level within that cavity. So this is cavitating necrotizing pneumonia, and a bronchopleural fistula is a very it can occur as a complication for necrotizing pneumonia in children, and they would require urgent pediatric cardiothoracic input because they have increased morbidity, and usually they have thoracotomy to get all the infection out. And when you're evaluating effusion on ultrasound, as previously described, you have to make sure whether you think it is a simple effusion, which is just anechoic, versus an empyema, where you would have loculation, septations, echoes. And always in CT, you have to look for the lung enhancement in complicated cases. If there is reduced lung enhancement, you have to highlight that there can be lung necrosis, and that predisposes to them developing the cavitation. And this is mostly seen with staphylococcal and Klebsiella infections, but rarely we see them with group B streptococcal infections and TB as well, just like in adults. And there's this another case. for you just to see that there is a cavity within the lung, and you can see the loculated pleural.
Divya, I'm sorry to interrupt. Can you point out the findings on the imaging, because some of them
I'm
can't
not
see
able
what
to
you mean.
move the laser. Sorry, it's stuck there. Hang on. Bear with me. Sorry, Toby. My laser pointer has stuck. Okay, now can you see it?
Yeah, I can see it now.
Okay, let me go back to. Okay. So this is the collapsed right lung, which was well enhancing, as you saw, and there's no area of necrosis within this one. But if you see this lung, there's this big cavity, and you can see an air fluid level within the cavity, and you can also see these loculated pleural effusion that is seen along the costal pleura here on the left and along the mediastinal pleura. And on the sagittal view, you can see it really well, the loculations, and the lung adjacent to it is tethered along that. Here you can see how the collapsed lung is enhancing here like a tongue, but you can't see enhancement of the lung here. So all this is concerning for further necrosis. So this is a case of necrotizing pneumonia. This child had chickenpox 2 weeks ago, and the source of infection was group B streptococcus, which sometimes enters through the skin when the pustules are breaking, and then it goes through hematogenicity and causes lung infection. So another case where this is a case where you can see that they have developed a bronchopleural fistula. So again, the lung is not enhancing, and there are areas of cavitation within, and there's a pneumothorax where they have put a drain in. So these cases are very much prone to develop bronchopleural fistula. So always look for lung enhancement on CT, just as you would in the liver. If there's non-enhancement, then you are concerned about necrosis.